Okay, so really just some couple of 3D TEs. The one on the left is basically a normal valve. There's a little bit of thickening. That's the standard orientation on a 3D TE that we like to demonstrate with the aortic valve at 12 o'clock. Lateral on the left, moving medial on the right side of the image. The leaflets at labeled. So that's a patient with just mild leaflet thickening. We would probably call that just degenerative valve change. That's a very broad and generic term, but that's clinically what we say. The one on the right is a different patient. That's somebody who has prolapse of the middle posterior leaflet. And you can see that let's see, this sucker should work. Oh, even better, I have my pointer. Okay, so it's just two examples. This is basically a normal valve, a little bit of thickening, not quite normal. But I show this slightly different view, really just to show, in terms of the mechanobiology and the sort of a primer on the valve anatomy, which is largely what this session is about. I want to show the sort of interrelation between the aortic and mitral valves. Watch closely as the aortic valve opens in systole, there's a bulge, and this intervalvular fibrosa, or the aortic mitral continuity, moves slightly to the right of the image. So that's the systolic pulse coming up through the aorta that's actually influencing the anterior part of the mitral annulus and helping to close the mitral valve. So the two valves are interrelated. One opening helps the other one close. So that's important as we start talking about TAVR and surgical valve replacement and mechanisms of repair and types of repair and pretty soon transcatheter mitral valve replacement. Just recognizing that there is this synergy between the valves is very important. Also, same valve looking from the bottom. This is looking from the ventricle. All we've done is we've taken the aorta on the left side and just kind of pulled it all the way over and flipped over the valve. So the aorta's over here. And this is really to emphasize the LVOT and how much of the LVOT contour is actually created by the intermitral leaflet, the ventricular surface of it. So it really creates a baffle that starts the flow up and out the LVOT. So anytime your anterior mitral leaflet doesn't have the normal configuration, you're going to affect the quality and perhaps even the quantity of flow that you eject. The chordae are cut off in this view. You see a couple of chordae over here. So Jane just took us through anatomy. We kind of go over this. The basic components of the entire mitral valve complex include all of these things: annulus, leaflets, primary, secondary, tertiary cord, and of course a papillary muscle and ventricular geometry that's still normal because the paps have to be in the right place for the cords to be relatively long enough to allow the valve to close properly. I really only show this slide to show the bishop's mitre that came with chordae. I've never found another one that actually had chordae stuck on the end, so that's what those are. All right, so we've got this valve function, and again, this is just sort of a little cartoon to emphasize this. This is sort of an animation of a pathologic slice, but really, mitral valve opens, creates this sort of vortex of flow, and emphasizing what I said, the anterior leaflet has to get up and out of the way, and really begins the tunnel that creates the LVOT. So the mitral valve has a job that's more than just preventing backflow. It's actually a baffle that gets the flow efficiently out of the ventricle. So that's important to recognize. When you look down on the mitral valve, the anterior and posterior leaflets are very different, and you're going to hear quite a bit more about this from Dr. Laurie in his lecture. But really sort of the analogy, and I think it's Dr. Laurie who probably taught me this one, is the posterior leaflet almost comes in almost like an airbag. It doesn't have a lot of up and down motion. It's really an angular motion coming in and out, whereas the anterior leaflet tends to just sort of fall into the ventricle, almost like an upside down toilet seat. It falls in and comes back out. So the motion of these two valves is really quite different. Okay, so let's get to a quick case. 68-year-old gentleman comes into the ER. He's got labored breathing. He's a little hypoxic. He's got crackles. JVP is marginally elevated. Carotid upstroke's okay. He's got a PMI. He's a little bit displaced. He's got a systolic murmur and a diastolic murmur and an S3 and a little bit of edema. It's an absolute disaster because the echo lab is closed. So we get this really old-fashioned imaging modality. But we get this x-ray. And really I show this really to sort of emphasize the pathology that happens here. We have pulmonary vascular redistribution, pulmonary edema we can see there. We have an enlarged LV. We have an enlarged LA, sort of splaying of the carina, emphasizing just sort of the pathology that can happen with chronic mitral regurgitation as a volume overload of the ventricle and the atria. They both get enlarged, as well as an increase in pulmonary vascular venous pressure and the pulmonary edema. This is the echo finally when the echo lab reopens. We get the echo, and you see a couple of things. So you see All of these sort of multiple 2D slices, this is a 3-chamber, a 2-chamber, and a short axis, but really you can just look down at the live 3D TE with the aortic valve positioned at the top. You can see that there's a problem here with the middle scallop. And we've got a still image of this in a second. Jane showed us already the importance of the chordae, and really there is no valve if the chordae don't work properly. This is that same patient. This is a still image of a ruptured cord. So whenever you see the posterior leaflet, sort of, and it looks here like it's giving you the finger, that's really a chordal rupture, and that's a flail scallop. Okay. So why do we get flail scallops? And we'll come back in a second, really just talk about how that happens. So this is sort of a fundamental question of anatomy that is becoming more important when you hear about repair and when you talk about surgical repair techniques, and now in an era about to get into transcatheter mitral valve replacement. And really the question is simply, where are the papillary muscles in relation to this mitral valve? And there's 3 options. So this is the standard orientation I've just been showing you, the aortic valve at 12 o'clock-ish, maybe 1 o'clock, posterior leaflet, anterior leaflet. And the 3 choices are, do you put the pap muscles under the mid-anterior leaflet and the mid-posterior leaflet, where the posterior papillary muscle sends its chordae to one leaflet? The other option is the papillary muscles are roughly positioned under the point of the commissures. They send some cords to anterior, some cords to posterior, no cords cross the midline. Or the pap muscles really sort of under mostly the anterior leaflet. The vast majority of chordae go to the anterior leaflet, and a couple of cords go to the posterior leaflet. Those are sort of the 3 main options, and I won't get you to put your hands up, but I've asked this question several times over several years, and it's usually a third, a third, a third. There tends to be a lot of uncertainty around this fundamental anatomy, and the answer is B. The pap muscles exist under the commissures, equally distributed cords roughly, maybe a slight predilection towards the anterior leaflet, and no cords crossing the midline. So as we think through the mechanism of valve dysfunction, it's important to recognize this sort of geometry. And that's shown here, similar kind of slide, just looking at a schematic, pap muscle, the vast majority of cords, and absolutely no cords ever cross the midline. So fibroelastic deficiency is the terminology that's now been employed to describe basically increased glycosaminoglycan content, somewhat weakening of the chordae and ultimately of the leaflets as well. And there's really a continuum. You can have a single ruptured cord, kind of like the one I showed you, multiple cords, and increasing amounts of leaflet thickening as you go, and then finally at the far end you'd have what we call a Barlow's valve, which is big, thick, and bulky leaflets, increasing the complexity of a mitral repair. Second case, 69-year-old gentleman from out of state. He comes with questions about mitral valve repair options. He's got dyspnea. His history is important. He's had prior infarct, prior bypass, a redo bypass, a defibrillator, and some heart failure meds. This is his echo, long axis. You can see that the mitral leaflets don't have a large coaptation zone. They really just have a little bit of touching at the tips. So that's your first clue that there's a problem with the mitral valve. If you put the color on, you look at 2 different beats, and this is not uncommon. One beat you see one color. If you keep watching, the second beat shows a little more color. So the question is that significant MR? We're going to hear more about that today, and really part of my setup here is to set the stage for the talks by Dr. Grayburn, Dr. Barker, Dr. Zogby. They're going to take us through some of the quantitation and the imaging approach to the mitral valve. But let's look at this LV in the long axis view at 2-chamber. You can clearly see LV dysfunction, but importantly you see this tethering here of the mitral valve and this sort of systolic tenting. In systole, leaflets don't come down anywhere near the annulus. They stay up tented with the tips barely touching. So that's chordal traction. That's the cords that are relatively too short now to allow the valve to close. And there's the color, which looks significant, hits the back wall, and we're going to hear more about the quantitation in a moment. Clearly, if you put a pulse wave Doppler at the tips, you see that there's a high velocity of the flow in early diastole. One of the markers that there's quite a lot of regurgitation and a lot of flow coming back. And if you sample the pulmonary veins, you can see in that color that there's systolic reversal in the pulmonary veins, so suggesting a significant MR. So this is really what's happening. This is a normal architecture on the left. Myocardial infarction occurs. Now you have a relative displacement of the myocardial wall that the papillary muscle is attached to. So the cords did not get the message that they needed to get longer, and they don't. So now you have this sort of tethering, and you can see it on an echo. You see this little sort of bend in that anterior leaflet. That's abnormal. And sometimes that's the thing you see first. Even before the wall motion abnormality is recognized, you can see that leaflet doesn't look normal. Why would a leaflet look like that? It looks like that because the cords aren't allowing it to come all the way back. And that's the clue that, there's a wall motion abnormality right here. And the color shows MR. Just to show here, if you look at the LV up at the mitral valve in systole, the aortic valve is open, so this is systole. You're looking from the apex up. You can see that the mitral valve is also open, so that's a problem. And this is another example of functional MR with this crescent-shaped orifice here when the leaflets get pulled apart. And the color would be like this, sort of broad in one view, narrow in another view, and a short axis shows this crescent-shaped defect. We'll hear more about that over the course of this summit, but one of the concerns with applying techniques like PISA is that the hemispheric assumption really doesn't apply if you know that the flow looks nothing like a hemisphere. Final point is just in terms of sort of a primer on the pathobiology is to consider the timing of the event. These are 3 different examples of MR, holosystolic functional MR, and if you put a color Doppler on, which you don't do very often, but it's a nice depiction of how the MR occurs throughout the entire systolic phase. This is a case here with prolapse, but the prolapse occurs early, and the MR occurs throughout all of systole. And a different case of prolapse, where the MR occurs just very late. So here's the QRS, there's really no flow until systole is almost over. So one of the things to recognize in the quantitation is how long does the MR actually occur for? So final slide, in the approach to sort of the pathoanatomy, it's important to consider the mechanism, whether primary or secondary, consider the timing, and of course the quantitation. The quantitation really does require consideration of the timing of the event. And then the final thing is you have to look for consequences of it, which is basically LV dilatation, LA dilatation, pressure increase, and forward stroke volume loss. So I'll stop there and we'll rediscuss more in the Q&A session. Thanks.